This event is being hosted through a collaboration between the Denver Prevention Training Center and the Pacific AIDS Education Training Center. We are really excited and have had a great time collaborating with our colleagues at the PA-ETC. So right now I'd like to ask Jadon and Brian to do a little introduction of yourselves and the Pacific AIDS Education Training Center.
Thank you, Bev. I'll go first. This is Jadon. I'm from the Pacific AIDS Education and Training Center. We're located in San Francisco, California, but we work in California, Nevada, Arizona, and Hawaii. And yes, I have been to Hawaii for work. It's an excellent trip. But we really provide capacity building assistance across these four states, and we have a regional approach, which means that information that we have that's developed in any one of our ALPs can be shared. So we really rely and leverage all of that capacity building and expertise of our faculty across the region to provide the best information to you all. So I'm going to let Brian introduce himself and one of our other programs that's really important for you all to know about if you don't know already. Thank you.
Hi, everybody. Good morning. I'm Brian Abascal. I'm a project manager at the Pacific AIDS Education and Training Center. And in addition to everything else I do, I'm also the coordinator of the HIV Learning Network, which is a bi-monthly webinar series that we do on the second and fourth Thursdays of the month. It's at noon Pacific time. And we try to have a pretty wide range of topics that are related to HIV care and prevention. So hopefully after this, this is something that you'll want to tune into later. But that's it for me. So I'll turn it back over to Bev.
I'm going to ask, thank you, Victoria. I'm going to ask Ty to introduce himself and the Denver Prevention Training Center.
Good morning, everyone. My name is Ty Edward Few. I am the manager of the Capacity Building Assistance Center at the Denver Prevention Training Center. We are funded by CDC to provide clinical HIV technical assistance and technical assistance to people living with HIV. Our region is the West region. Those are the 15 jurisdictions in the West. And we are so happy to have each and every one of you. We are so ecstatic about this time. Thank you, Bev. Thank you, Jadon and Brian, our partners at the Pacific AIDS and Education Training Center. And thank you to our Zoom goddess, Victoria Myers. Have a great day, everyone.
As you can tell, this is a collaboration really between HRSA and CDC, which is really, if you think about our kind of federal perspective on HIV treatment and services, this is a really robust way to bring together resources and bring all of you together to share ideas and innovations. So last but not least, I'd like Victoria to introduce herself. You met her and she's kind of been guiding us so far. She's going to give us some more tips on how to kind of manage our space as we collaborate during this meeting.
Thanks, Bev. Well, welcome everybody. Again, I'm Victoria Myers. I'm our distance learning coordinator in the Denver Prevention Training Center. So I work with Bev and Ty and some of the others that are on this call. Some Zoom tricks for you all. To unmute yourself when you have a question later on, you can just hit unmute on the little microphone. It should be on the bottom bar of your screen. It may be on the top for some of you. You can also start your video. Many of you are on camera, so thank you so much. We love to see your faces. It makes it so much more collaborative and interactive. I will ask you to start your camera, so don't be surprised when you see that pop up come on your screen. But you can stop it if you need to go do something to take care of yourself. There are some views for how we can all see each other. So in your top right corner, you'll see either speaker view or gallery view. Speaker view will highlight one person who is talking. So if you have that, you see my face a lot larger than the others. So take that off and put it on gallery view so you can see everybody. And it's like Hollywood Squares or the Brady Bunch, depending on which one you want to go with. Because there are so many of us, currently there's 293 of us on the call, we have multiple screens. So you'll see in the middle to the right where it says 1 through 7, or it might actually say something more depending on how many you can have on your screen at once. But you can click that to see if maybe some of your other colleagues around the States you want to go wave at or look at. And you can do that very quickly. Many of you are finding the chat box, which is wonderful. I'll say here, that's where the chat box is. If you have questions you want to ask, put them in there. You can either fill them directly to a person by clicking on everyone and then clicking on an individual, or you can send it to the larger group, which is the everyone. Those are the basics. Are there any questions with all of what I just went over? I know that was pretty quick, but I want to save time for the real presenters. Okay, I'm not seeing any. So the last one, and I'll reiterate it again, is please, please, please rename yourself to your first and your last name. This is going to help us immensely with our attendance. You can do that by clicking on the 3 little dots up in your box again, and then clicking rename, or you can do it in the participant box as well. But again, first and last name, please. And if you're watching with someone else, just go ahead and also put their name in there. So you could say Victoria and Bev, or Victoria Myers and Bev Wasserman. That is all I have, but please chat me if you have any questions or have any issues with your sound or video. I'm happy to answer them.
All right, we'll move on to the meat of our session today. So our objectives by the end of this meeting, we hope you go away with really having some ideas about key changes in HIV care and services during the COVID-19 pandemic, sharing lessons learned and innovations, and service provision during the pandemic as well. And finally, we have a list of resources we've collected to share with you, and you as well may have resources you want to share with this larger group. So I want to start by saying thank you so much to our panelists for joining us today. Our subject experts will share some of their innovations they've done in their clinics and programs. And again, this will help us all think about our own work wherever you are in the country, and what you've already done, what you may do in the future. We know things are shifting as we hopefully see the curve dropping down and seeing less cases of COVID. But again, we may find things that we want to keep that we've learned during this time where we've had to shift a lot of our care and services. So again, thank you to all of our panelists, and thank you to each of you for the work you do every day, the work you've been doing for years. We know that managing an epidemic or a pandemic is not new to us. So I want to say thank you and honor all of you for the work that you all are doing. So for starters, I'm going to ask each presenter, each panelist rather, we're not doing slides today. This is more of a conversational discussion and a time for sharing. We're asking them to share a little bit about their practice and who they serve, about how COVID-19 has altered their workflow, some of their biggest challenges, and then how did they overcome those challenges? What were the strategies and lessons learned that they'd like to share with you today? So I'm going to start with, hopefully Larry York is with us from Peterson Clinics in Arizona. Larry, are you around? No. I guess Victoria is telling me not yet. So we'll come back to Larry. Hopefully he'll be able to join us. Rob Phoenix, are you with us today? No. Okay. That's okay. We know Dr. Lubega is here because we saw her early on. So we'll ask Dr. Sammy Lubega from Lifelong Medical in California to share with us some of her innovations and kind of how they've worked around COVID-19. Thank you.
Hi, good morning, everyone, and thanks for being here together on this Friday morning. So I was going to share a little bit perspective from the Pacific region in the East Bay. So I am a family doctor, an HIV specialist at Lifelong Medical Care. We are an FQHC in the East Bay. We have a network of about 10 different clinic sites across Alameda and Contra Costa counties. But a vast majority of our people living with HIV are seen at about 3 where our HIV specialists are. We have a total of about 220 patients. Just to give you a general sense of the makeup of our patients, a majority are people of color, and a large percentage of those are African American. At a couple of our sites, our patients tend to skew a little bit older and more female as a demographic. One of our sites does see a lot more young MSM. And we have one very specific site that's actually one of our county-based homeless services centers. So our patients living with HIV who are also experiencing chronic homelessness often get seen there. There's a lot more drop-in capacity typically, and intensive case management for folks who are being seen there. So that was our setup pre-COVID, and COVID has pretty dramatically changed our workflows. So in general, every patient visit is now defaulting to a telemedicine visit. For the past, we've been operating like that for about the past 5 weeks now, with a pretty explicit plan to delay any routine care for stable patients and really focus a lot more on COVID education for patients, on dealing with acute needs, and keeping care moving to try and prevent any more acute or subacute things from popping up in the middle of kind of preparing for the peak of the pandemic. We have very limited in-person clinics for what is kind of absolutely necessary to do in person, and we have set up a whole protocol that actually spells out what patients should be seen in the clinic for. So things like scheduled injections of their antipsychotic, contraception, of their regular hormones, or specific in-office procedures like wound care and INDs that we can keep out of the emergency department. We are still to see in clinic. What we basically advise people about otherwise, thinking about sending a patient into clinic, really think critically about what a full set of vital signs and the eyes, ears, and hands of a provider might change their management. And if there is a clear way that you think that'll be impacted, to state that really clearly in the note, and then we have a referral process for getting them onto the schedule. Otherwise, we're really trying to actually empirically treat patients, close follow-up by phone, just to keep patients out of the clinic unless they really need to be there. So one of the requirements that we actually have right now is that a patient has to have a provider evaluation, or at least a provider okay, before they can even be scheduled for an in-person clinic. So we're really making sure we can do whatever we can clinically for the patient before exposing them to additional risk. When we do our telehealth visits, we do have our MAs as part of our workflow. So we still have one-to-one MA staffing for the providers. And that's actually been pretty critical for us. We found that because everyone is at home, sheltering in place, sitting by their phones, it means that our show rates are pretty close to 100%. And so we are still really doing volume medicine, and even though we're not doing the full range of things we would normally do in the clinic, we're just having to spend a lot of time with patients talking through what COVID means, through their plans for their HIV medications, talking through things that we would normally just be able to take a quick peek at or a feel of and know what to do with, and instead we're really needing them to explain or try to use their phone to show us, or grab a partner or whoever else is in the household. So that ends up taking a fair amount of time. So having an MA who's calling the patient ahead of time, heads up, their provider's calling half hour or so, and to wait by their, and the MA calling back at the end of the visit to do what planning, help them schedule an appointment at the lab if needed, and I'll come back to that, and make plans for a next visit is really still an important part of how we complete a more comprehensive telemedicine visit. In terms of our in-person clinic, just to give you a little bit more information about that, especially how it relates to our HIV care, We've set it up so we have, out of our usually operating about 10 sites, we only have about 4 sites in operation, and we've consolidated our patients geographically to be seen at the closest geographic site when they do need to come in. For our HIV care, we have consolidated it to about 3 clinics. So one clinic has had to shift all their patients to a nearby site. My clinic at East Oakland is still operating, and then the Trust Clinic, because they do some really specialized drop-in services for patients, is still operating in that model. We do only about 1 half day a week of in-person visits at each site. So there's one specialist who'll see any of the patients at that given site, even if they're not part of their primary care.
Victoria, can you hear Dr. Lubega?
I cannot. I think she might have froze. She's frozen on my screen at least.
Okay.
We may want to see if anyone else will go, and I'll email with her.
Okay. Have we had Larry or Rob join us? Larry York or Rob Phoenix?
Hi, this is Rob Phoenix.
Oh, hi, Rob. Thank you for joining us.
Sure.
Great. Rob is from the Hunt Ridge Family Clinic in Nevada, and you are a family nurse practitioner, correct?
That is correct.
Excellent. If you would share some of your kind of innovations during COVID-19, we'd love to hear from you. Thank you.
Okay. So I'm Rob Phoenix. I'm a nurse practitioner. I am the owner and the nurse practitioner for the Hunt Ridge Family Clinic, which is Nevada's largest LGBTQ affirming care clinic. We do a tremendous amount of work in the transgender healthcare. We do a lot of work in HIV prevention, a lot of HIV treatment as well. And then we do primary care for all of our patients. So with this whole COVID kind of thing, we've really had to refocus and restructure how we're seeing patients and how we're accommodating the day-to-day activity. So earlier this month, we have a social service agency that is downstairs with us. It's co-located in the building. And they had an employee who had a potential positive test for COVID. So the entire building got locked down as a result of that. So we've really had to refocus how we are managing patient flow and things like that. So we've put a Ring doorbell outside our door. So when patients come in, they push the Ring doorbell. It kind of lets us know they're there. One of the staff has to go downstairs and let them in, bring them upstairs. We've also started screening all of our patients coming into the clinic. So we have a list of questions that the staff call patients the day before their visit and go through, make sure they don't have any symptoms suggestive of COVID. And if they have symptoms, then we're not doing in-person visits with them. We're shifting those to telemedicine visits. For our lab draws, we have been either offering patients to come into the clinic if they have no symptoms, or if they're not afraid of being out in the community, if they're kind of socially isolating and they're a little bit paranoid about going out, we give them the option of delaying their labs or going to the local lab. So like Quest or CPL or LabCorp, and then we send an electronic order in. They schedule an online appointment with the lab, and then they go in and actually have their blood drawn at the lab site and then go home. And that's been working out pretty well for patients. They seem to appreciate that flexibility. The only difficulty is for our PrEP patients, we can't, the draw sites won't swab patients. So, we're not getting our oral swabs, we're not getting our rectal swabs. So it's a little bit of a challenge as far as that goes. But we're kind of working around that and trying to figure out ways to do that. We also, prior to this, had a collaborative relationship with a pharmacy here in town that does some of our PrEP navigation with us. And they actually have patients that come to the pharmacy pick up a kit that has their oral swab, their rectal swabs, a requisition for their labs, and then they actually collect the swabs at home, take them to the local lab, drop it off, have their blood drawn, and then the pharmacy manages their medications and sends it to them, or actually has a patient come back and pick it up. For medications, we have been trying to transition as many patients as possible to specialty pharmacies. We have about 4 or 5 local specialty pharmacies that we're trying to utilize so patients can actually get delivery of medication, so they don't have to actually go into the pharmacies or they don't have to leave home. And we've been transitioning everybody as much as possible to 90-day fills so that they're not running out of medications. For our positive patients, we have been kind of deferring labs if they're stable, if they've been on medication for a while and their viral load's been undetectable, their T cells are reasonable. We've been just kind of deferring those labs. Patients that are insisting, we're offering them, because some patients are like, hey, I need to have my labs every 3 months. I know I'm stable, but I just need that peace of mind that nothing's happened over the last couple of months. So in those situations, we're actually getting it set up so patients can go to like CPL or LabCorp, actually go to the draw center and have their blood collected there. For our in-office processes, we have really limited the number of patients that are in our office physically at one time. We were at the height of our operation, we were seeing anywhere from 20 to 40 patients physically through the practice, between our STD practice, which was largely walk-in, our PrEP program, which was both initiation and continuation. So our continuation for PrEP, we do like a swab and go. So patients come in, they do their swabs, they get their labs, they talk to one of our staff, go through a questionnaire about symptoms and medication adherence and things like that, and then they basically leave. And then for our walk-in STD, so we've really had to cut that down. So now we're seeing about 12 to 15 patients physically in the office. We have really changed our lobby. We used to have about 25 or 30 chairs in our lobby. Now we have about 12. So we've socially distanced our patients so that they're not sitting in bunches. We also have one of the needle exchange program vending machines in our office through Southern Nevada Harm Reduction Coalition. So patients can actually come in and still get their week's worth of clean injection supplies. We're also screening those patients via our Ring doorbell. So that when they come to the clinic, we're asking them the same questions and making sure they're symptom-free for COVID, and then we're allowing them to come in and get their supplies. And we've just really kind of had to change our practices to accommodate patients and try to keep patients coming into the office that want to come in, but also enabling patients who want to do telemedicine visits the opportunity to do that. We had started using a telemedicine program for our mental health a couple months before COVID started. And so we were actually kind of ahead of the curve with that. And we use a program called Blue Jeans, which is web-based, and we schedule patients a visit, and it's HIPAA compliant and secure. The patient gets a link with a password. They log in. I log in from my desktop, just like I'm doing here, and then we do our visit. I have a medical scribe that participates in the visits as well, so he does all the documentation with patients. And it's actually been pretty smooth as far as the telemedicine visits go. It's like patients are, they're actually showing up on time. I'm actually showing up on time, which is really impressive. And the visits are actually going really smooth, and the patients are really appreciative of the ability to stay at home and not have to come in for their visits and things like that. Most of our visits are averaging about 10 to 15 minutes, which is good. And patients are able to get all their questions answered. And, we're talking about COVID, we're talking about isolation, we're talking about the testing opportunities that are here in Vegas. Nevada still has really limited resources for testing. We are only testing patients who are literally being hospitalized, and it's largely just for isolation processes. We don't have, we haven't been able to secure testing supplies to do, mass testings, and we're not doing any antibody testing at this point, although we're hopeful that sometime next month we're going to have the ability to do some in-office testing for antibody testing. So, so one of the questions is Blue Jeans is the program that we are using for telehealth. We use that for our mental health providers as well. And we also use it for our medical provider, which is me. It works really, really well. and it's bluejeans.com. I learned about it actually from the University of Louisville, Kentucky. They use that for their hepatitis C program. So they do a lot of rural management of hepatitis C and out of Louisville. And I met one of their nurse practitioners at a conference, and she was talking about the program, and it's really easy to use. The disadvantage to Blue Jeans is I can't link in my translation services. So I have to have a staff member do my interpretation if I've got a non-English speaking patient. There are some other programs out there that do allow for the interpreter to kind of come in through a separate program, but unfortunately Blue Jeans does not do that right now. So, any other questions?
I think someone responded to the question about the 90-day fills. It sounds like you're not having trouble with insurance approving that.
So far, we are not having any, I'm not getting any report back that we're having pushback. I know like United Healthcare, which is a big provider here in Las Vegas, actually has sent out some communications to pharmacies that said that we are encouraging you to do 90-day fills in this this kind of pandemic situation. So United Healthcare has been very proactive in getting patients set up with 90 days. And that's the other reason why we've been transitioning patients away from the big box stores to the specialty pharmacies, because they're willing and able to do that. So we have, Avella, there's All-in-One, there's ESP Cares, there's a couple other smaller specialty pharmacies, and they're willing and able to spend the time with the patients on the phone and with the insurance companies and getting them set up for those 90-day supplies. And they also deliver to the patient's home, and that's free. So they just, kind of drop it, knock on the door, kind of like the, what do they, doorbell.
Kind of like the food, right?
All over the kids. So it's just about leaving flaming dog outside. They're leaving their medicines.
And Rob, is Blue Jeans spelled B-L-U-E Jeans J-E-A-N-S, or is it
exactly like it sounds? Exactly like it sounds.
Just like bluejeans.com, correct?
Yep. And it's actually reasonably priced. I think our subscription for the year was around $500. And I have myself and 2 therapists and a occupational therapist that are under our license. So they all have like their own rooms that they use. They all have their own ability to schedule patients. We can all 4 be on there simultaneously in different rooms and things like that. And it's actually really helpful.
Great. And then there was a question about labs, the anal swabs, and getting that lab done. Can you describe that a little bit more? Is that,
yep.
So is that being done in the pharmacy, or how is that working?
So we have tried to work with Quest and LabCorp and CPL about collecting swabs for patients in their draw centers, and they've just kind of pushed back. They won't do the COVID swabs. They don't do flu swabs. They don't do swabs, anything like that. So this isn't like something like, oh, it's sexual health, we're not going to do it. Just we don't do swab questions in the lab, in their. Yeah. So what we've done for our pharmacy collaboration program is we actually built little kits that has a lab requisition, a swab and a container for a rectal swab, and a swab and a container for a throat swab. And the patient gets that kit from the pharmacy when they go in. They go home, they collect their swabs, they go to the lab, they get their blood drawn, they drop off the swabs in the lab. The lab is fine with it if you collect it outside of their space. They just don't want you doing it in their space. So that's been working really well. For our patients who come in the office, we just had them do their swabs here in the office, and we send them in just like we normally do. And then there was a question about the doorbell. So I use Ring doorbell, R-I-G, the one you see on TV. So patients, push a button that has a little video so we can see who's actually there. And it has 2-way communication. It's really nice because, it's connected to a cell phone. So we can actually, talk to the patient. It works really well. We tried doing Text Now, which is a free program that's just for texting. And we had a number on the door where patients could text us when they got downstairs. That didn't work quite as well as the doorbell has been working. So we have one downstairs at the main entrance because our main entrance is locked to the public. now, and then we also have one outside of our door in case somebody kind of sneaks in. So we're keeping our office door locked as well because we're just trying to. And I've really only had one patient that's given us any kind of grief about not accommodating the whole COVID thing and their prep and pushing their labs back. And I'm like, listen, if you are not socially isolating when it comes to sexual behaviors, then you need to get your labs. If you are sexually isolating yourself and you're not active, then you don't need to do labs. You can take a holiday. And, that's kind of my, my approach to patients that are on PrEP is, just be careful who you're hooking up with because you might be stuck with them for 2 weeks.
Thank you, Rob. Quick last question for you was what the name of the texting program was, if you could restate that.
Yep, Text Now, TEXTNOW.
Okay, great. Thank you so much.
Mm-hmm.
And stick around. There may be other questions later. I wanted to thank you all for asking great questions as well. So I wanted to go back. I believe Dr. Lubega was able to rejoin us. So we've heard a lot from Rob about shifting practice, about collaborating with pharmacies, working with the labs, using doorbells. So Dr. Lubega was letting us know about how, like in the FQHC model, things have been shifting around. So are you still with us, Dr. Lubega?
Yes, I am. Sorry about that.
Excellent. That's okay. This is the virtual world, right?
The world of home-based Zoom.
I could disappear. Yeah. So please continue sharing.
Yeah, and I heard some of what Rob was saying, and I want to make sure I don't repeat, so maybe I'll just add a couple of highlights that I can share from our own experience with the workflow. Is that in terms of our specific patients who we're seeing in clinic, we are still trying to make some specific exceptions that are HIV related. So any new diagnosis disclosures, which we haven't had yet. There's one that we were trying to track down and weren't able to. Rapid ART starts, we're still trying to do. And we interestingly have had a couple of new re-engaging patients because they called in seeking COVID testing and weren't actually looking to be reconnected to HIV care, but we noticed HIV was on their problem list or some other reason, and we were able to hook them into care that way. So that's certainly still happening, and something that made us realize we need to pay extra attention for those opportunities. Our unstably housed patients or patients who have unstable access to a phone, we're still encouraging them to drop in and trying to signal to them about the times that we have our HIV providers available so that they can know preferentially to drop in at those times. And if someone does drop in, we try not to turn them away and try to just address what we can for them as quickly and safely as possible. I see a question about PrEP startups, and we are actually seeing our most high priority PrEP starts, or what some people call high risk PrEP starts, but we really think this is an opportunity. We do actually try to see them in clinic and get their starting labs in clinic. We still think that it's really important to get those startup labs as close to the day of starting, that we maybe don't need to necessarily delay starting PrEP until the lab's result, but we do try to get them drawn at the same time that we're starting PrEP. The other thing I would say for labs is that we here in the Bay Area, Quest Lab has started something called the Peace of Mind program for older adults, where the first hour that the lab is open is preferentially for older adults, I think 60 and above, but I think that's a program that's available at a lot of labs, which is helping our patients just be able to schedule lab appointments, and sometimes we're having our assistants just schedule those appointments and call the patient and let them know when their lab appointment is if they do need to get labs. We've started sending self-swabs home to patients similarly if they don't want to come in for a swab and go or can't, and if they have already been comfortable self-swabbing, doing kind of the same thing where we set up all the stickers and the labels ahead of time, and then the medical assistant actually sends it to the home. And so far that's actually been working out well for patients. And then one thing about accessing medications that I'll add, there's been a couple of times where I've actually called the pharmacy and asked for patients to be able to pick up medications early so that they can pick up all of their medicines at once and not come back for the one refill that's due this week and then the controlled med that's due 2 days later. And they've actually been surprisingly accommodating, even with controlled medications, pushing up that pickup date to minimize the patient coming in. And similar to Rob's experience, we found that our local specialty pharmacies have been particularly great with helping to set things like that up, to do 2 to 3 months worth of refills at a time, and to do delivery. So I think I will maybe stop there, other than to say that I think one of the biggest challenges for us in terms of our HIV care is that our case manager especially is very close to a lot of our patients. And we've done a really great job creating this kind of relationship-centered care. And now we are really worried about those patients that we just don't have those close, frequent contacts with in the same way. And so we're really trying to trust that the relationships that we've built over time are going to persist through COVID, but we're also trying to start making sure that we're going back to all the patients who maybe aren't calling or coming to the clinic as much, and really make sure that we're doing special outreach to them to at least stay connected. Some patients we've noticed are doing too good of a job of trying to stay away when they're actually things we could be helping them with. So we just want to make sure that we are able to find that balance again in the new telehealth model.
All right, thank you. Thank you so much for sharing. And again, I think we heard a lot between you and Rob about transitioning to less face-to-face, but at the same time, you spoke to keeping those relationships. And I think everyone is stressed right now and anxious. And of course, if we have strong relationships, our patients and our clients look to us, for some degree of comfort and education and acknowledgement, and letting them know that, we will get through this and you'll still be taken care of. But I think you bring a really important point about how beneficial those relationships are during an episode like we're going through now. And maybe there's an opportunity to build relationships with clients and patients who we haven't had those close opportunities with before. Someone did have a question, which we could also bring up later, because Nate's going to tell us a little bit about linkage work, but someone asked about how patients feel about telehealth visits. Are there any immediate complaints or generally it sounds like Rob said that actually the patients show up more. He shows up a little closer to schedule. Sounds like we're learning that we're seeing the benefits of telehealth. Dr. Lubega or Rob, any thoughts on how patients experience telehealth?
So, overall, patients have seemed like they're really satisfied with the visit. They appreciate the fact that they can do it from home and not have to go out in the community right now. We haven't formally surveyed anybody to say, on a scale of 0 to 10, what's your satisfaction? What's the likelihood that you would want to continue to use this in the future? But the general perception is that it's good. I haven't had a single person that's complained about why can't I come to see you? Except for one of my PrEP patients. He was angry because he has symptoms and my staff told him to stay home. He's like, I tested negative for COVID. I'm like, there's a chance that that's a false positive or a false negative. And as long as you have symptoms, we are not going to see you because we need to protect our staff and all of our patients. We can make arrangements for telemedicine visit, or we can make arrangements for you to go to the lab and get your stuff done there, but you cannot come to the office. We've had to put that safety in place just to protect all of our patients because of the population that we deal with. And the risk that, it's diabetic,
and I think,
blood pressure.
Yeah, there's resistance to change, right?
Yep.
It's always uncomfortable changing. But yeah, someone in the chat said that patients love telemedicine visits. So again, and we hear that from some other groups that have been doing telemedicine already. That is the message they're getting. And it's surprisingly a way to address sometimes stigma and even medical distrust. So anyway, more to come on the telehealth. So I believe Larry York is here on the call, and he can give us the pharmacy perspective. Larry, are you here?
Yep, can you hear me okay?
Yes, thank you for joining us.
All right, so I guess a little bit about me. I'm located at the Peterson HIV clinic that's in Tucson, Arizona. We're through the University of Arizona, but we're housed within Banner. And the way our clinic is set up is it's more of a collaborative team approach. So we have an ID physician, we have one of the 3 pharmacists, and one of our 3 coordinators that all see the patient at the same time. So as far as COVID affecting our workflow, really the largest barrier for us was just figuring out how to maintain that connection. So trying out platforms like Zoom honestly was the first thing that we gave a go of. And essentially having all 3 of us present at the same time with the patient, addressing all their concerns. And that has largely worked out really well. So I think it's mostly phone visits that we're doing right now with our patients, but we're utilizing some different platforms. Banner has their own platform that they've built for us to try to use. And we're just keeping everyone on the same call. So in the same visit, our patients are still able to have their visit. We're still able to address any medication issues, get that squared away, and then get squared away with any possible insurance problems, scheduling, anything that remains. So as far as lab work goes, that one has been a little bit more hit and miss. It's very case specific. I heard someone mention earlier, so if they are sexually active, there is more of an incentive for us to try to get these patients to have their labs drawn. And we're utilizing specific labs. So for example, one of our clinic campuses has a lab there, and we know that there's certain times that there's really nobody there. So we are able to make recommendations for people that we absolutely need to get labs on or feel like there's more of a pressure to do that than for some other folks. The swabs we're still working to address right now. We do have a nurse practitioner and any of our providers are willing to go in for select patients. We're working on getting some kits set up to do mail-out testing and having those patients then deliver them. But we too have the same issue. There is a lot of pushback from Sonora requests to actually get these swabs or LabCorp. So we do have to have them collected and then delivered to the site for them to actually perform these tests. Then lastly, regarding accessing medications, I can honestly say that's probably been our least significant problem. We work with a bunch of different pharmacies. The major 2, Banner has a specialty pharmacy in their hospital, and there's a local community Walgreens that we've been using. They all do mail delivery. Where possible, we're getting 90-day supplies sent out to patients. The community, I think, utilizes the doorbell technology to limit exposure if possible, and honestly has not had any complaints there as far as accessing medications for our patients. So really for us, the biggest challenge was, I think, just managing to keep the cohesiveness of the appointments together. I think that's one of the strengths that our patients identify, is just having everyone readily available to kind of just knock everything out in one go. And I think for the most part, we've done that. I think there's still some stress connecting patients in terms of technological capabilities, but we finally, I think, have found a kind of some stable footing, and things have been going pretty well.
All right, thank you, Larry. Thank you for sharing kind of your overall strategies and what you found effective, what you want to continue to work on. It sounds like you just shifting to the kind of one-stop shop visit is your ultimate goal. And is that something you would see your group continuing after this epidemic? Yeah, I think the only question moving forward, we've been doing kind of the one-stop shop approach for years now. I think it's more integrating if patients want to continue with a telemedicine platform, how exactly to integrate that. Some issues there is just kind of the disconnect that there may be since we are through U of A, but we're also housing in Banner, so it's just trying to make sure that we're on the same page with everyone that's involved in patient care. But other than that, it is a one-stop shop model. We're following up with the patients, and I think the primary issue has just been making sure for patients that we really don't recommend getting labs,
who have maybe some significant other COVID-related comorbidity that we're worried about. Is just trying to make sure that there's not an issue with potentially their Ryan White funding, as they do often here recommend getting LASIK every 6 months.
All right. Thank you very much. I see someone put a question in there about syphilis. If you don't mind, Dick, I'm going to hold that question, but that's a really, really important question that I want us to address, but I want to get through the next few presenters, and then some of our clinical providers can speak to that, like how your program is managing syphilis screening. So next I'll ask, let's see, we got Larry on. Nate Gibson's gonna join and speak to us a little bit about linkage to care. We've heard a lot of clinical models, we've heard about the pharmacy, and now we're gonna hear about linkage to care, and Nate is with Denver Public Health and one of my colleagues in our department.
Awesome, thank you so much. Can everyone hear me? The thumb up, awesome. And before I actually get started, I just want to say I'm watching the Zoom gallery and I've seen people dancing and I love it and I'm living for it. So everyone keep smiling and having a good energy right now because we need it. And so, but yeah, I'll go ahead and get started. If you see me looking down, I typed up some notes, so I'm just going to be looking at my papers here. But yes, my name is Nathan Gibson and my pronouns are he, him, his. And I've been with Denver Public Health for about 1 year now. However, I've been working in this field for about 10 years. And so for the next about 6 to 8 minutes, I'm just going to go briefly over our Linkage to Care program and how we've adapted through all of this, as well as just the PrEP navigation piece specifically, because that's typically what my role entails, is a lot of the PrEP navigation. And again, just thank everyone for taking the time and allowing us to share our experience. With Linkage to Care at Denver Public Health, our patient population includes individuals who are newly diagnosed with HIV, as well as living with HIV and out of care. It also includes individuals who are newly diagnosed with hepatitis C, as well as PrEP navigation. And then we also have a staff member that's dedicated to Linkage to Care at the jail and in regards to HIV. Typically with our Linkage to Care referrals, we tend to get them from our walk-in clinic, which is where we do most of our work, as well as the outreach program, outside agencies, self-referrals, all of that. As far as our PrEP program, we've had since February 2018 about 1,300 PrEP starts in that program, and approximately monthly we have about 40 to 50 PrEP starts, as well as 70 scheduled PrEP ongoing care visits. And so it's very busy with PrEP at that clinic. With the Linkage to Care, who also serves as PrEP navigators, we help enroll patients in patient assistance programs, as well as work to help find that ongoing PrEP provider. A lot of the patients that we see for PrEP at that walk-in clinic, anyone can be seen as far as the PrEP start goes. However, for ongoing care at that clinic, they would need to be uninsured. Otherwise, if they are insured, we help navigate them and connect them to that ongoing care. Right now, due to COVID, Linkage to Care services have moved to almost 100% telephone visits. And so it's pretty strict to just telephone for the most part. With our PrEP program, we have not seen a noticeable decrease at this time, because immediately as soon as everything happened, we actually switched to teleprep. And so it was a lot of moving pieces and a lot of departments had to come together for it, but we were able to do that. With the teleprep program, we're able to do PrEP starts as well as PrEP follow-up. Occasionally, we'll still get a few PrEP starts for individuals that are coming to the clinic itself, but the numbers of individuals who are being seen at the clinic are extremely reduced. And so typically it's individuals who are symptomatic and are doing STI checks. With teleprep visits, those then include a lab-only visit, so the provider then will be able to coordinate with the patient and have a lab-only visit scheduled where they'll come into the clinic, do the self swabs and all of that, and do their lab work, and are able to do that at their convenience. Also, with labs, HIV, gonorrhea, chlamydia testing will soon be available through mailing home testing kits. And so that's a project that's being worked on right now. And I think that may be starting very, very soon, within a week or so. And so that's exciting. As well as the medication piece, most PrEP patients are coordinating with our pharmacy to have the medication mailed. Some of the medication pickup is happening still on site, but most of it's being mailed. Also, utilization of local pharmacies closer to the patient is encouraged as well a little bit more. As far as attendance to the appointments, we've actually noticed by switching over to teleprep that the no-show rate has been reduced by at least 50%. And so people are showing up, people seem to be extremely happy about it, and so that's been really great. As far as the navigation piece, it gets a little tricky because it is a little kind of hot potato on the phone. And so after the patient meets with the provider, the linkage to care staff or PrEP navigator at that time is contacted, and we're actually able to speak with the patient in real time and kind of assist in enrolling in patient assistance programs and kind of looking to see what that next step's going to be. And so anything outside of a PrEP start, though, that's not immediate prescription access, it's typically notified to us through our electronic medical record to one of us, the staff members, and then we'll follow up with the patient. With the patient assistance programs, we've actually been lucky, especially in PrEP. A lot of those programs have given availability or approval for verbal consents. And so that's been great. And so being able to do stuff over the phone, help applications or help patients complete the applications, and then submit those applications either via fax or encrypted email. And so that's been working smoothly, as well as after the telephone visits are completed, there is a secure messaging system that we have with our electronic medical record called MyChart. I'm a very visual person myself, and so I know a lot of the patients that we are as well. And so just to have that communication just on the phone can be difficult to know what those next steps are. And so with MyChart, with that messaging system, a lot of what we're doing is we're doing visit summaries. Then after our visit, we do a visit summary and send it to the patient so that they can just have a reminder of what was talked about today. If they have any additional questions, have ways that they can reach back out to us, as well as some of the educational documents and all of that. We've made sure to scan that and have that available in our system so that we can actually attach those in those MyChart messages to patients, which is great. And so it takes a little bit extra time doing MyChart messaging then that way, just because you're wanting to give as much as you can to the patient. But I think it's useful, especially in this situation. On the back end, some of the navigation stuff is for teleprep visits that are scheduled. We actually go in and we verify all enrollment dates and patient assistance programs that morning of, just to make sure that we have the latest information for that patient in the system. Also, as far as smart phrases, we created little smart phrases and stuff with this situation, just so that that helps streamline communication, as well as meeting with staff. We just do regular check-ins, like I'm sure everyone is. I noticed some things that I think are helpful with our check-ins, especially with navigation piece, is we've actually made them almost like a chart in the email where we have sections where it's lab, medication, all the different pieces, and so that it's kind of easily visually to be able to go through. I would say the biggest challenge is just not being able to see the patient face to face. A lot of, especially all of us in this field, but especially navigators and stuff too, like we really want to develop that trust, and it can be hard when you're not seeing a person directly face to face. And so, or picking up on those nonverbal communications, stuff like that. I would say the thing that's been the most helpful is just as tough as it may be to always be staring at the screen and sending emails and all of that on such a regular basis, or Zoom meetings, it's so important to make sure that there's communication happening interdepartmentally and just making sure that everyone's on board on what's happening, so that the message we're giving to the patient is also what's actually happening in that moment. I would say overall, though, patients have been very happy with teleprep and giving great feedback and rolling with the changes. And I think they're just happy to not have to come in and just be able to stay at home and not be out at the moment. I think next steps would be kind of moving to that virtual, being able to have teleprep services virtually with patients. And I think we'll definitely be utilizing some of these resources and services in the future too, because it seems to have a really great effect.
Okay, thank you, Nate. A couple of comments here, or questions here. I will say that we do have, our program is housed in the Denver Health and Hospital System, and we do use Epic. I'm not sure, Nate, do you use Epic as part of your navigation work?
We do.
Okay, great. And also, Julia just commented here that we are all considered essential employees. However, still the focus is trying to do less face-to-face work. So the remote telehealth visits for HIV and PrEP are the, that's the preferred way to interact with patients right now, especially, until our rates are starting to really flatten in Colorado. Someone asked, Nate, what do you resort to if patients don't have access to MyChart?
So if a patient doesn't have access to MyChart, we still do everything over the phone. It makes things easier, and we're able to kind of add those extra materials and stuff to just reinforce kind of what had happened. But typically, if a patient doesn't have MyChart, what I like to do is I actually will put a reminder to myself to make sure to pay extra attention to that patient and give them a call in a few days and check in, make sure everything was done, if they have any additional questions later on, and kind of make sure that there's open communication that way.
Thank you. And then there's a question probably for any of our clinical sites, or Nate, you might have experience with this, asking, is there a HIPAA compliant e-sign software? I think that's for those who have like a formal telehealth program. Anyone have thoughts on that or experience?
I know some things are getting signed when people come in for their lab visits. And so sometimes those lab visits are done kind of in preparation.
Yeah, someone said they're going to be using something called Nitro, but haven't used it yet. Thank you for that, Sarah. San Bernardino, Jessica said, found it difficult to maintain contact with clients because of the homelessness barriers. Yes, we know that's kind of a whole nother sphere of kind of how we stay in contact. I'm sure people have to be more mobile and move around in ways they didn't before. Because of just everything being different, and the expectations in our communities is that people are at, quote, home, but if folks don't have a home to go to, then where do they go? I know there's been a few shelters created here in the Denver area, but that's kind of another area that we really have to address when we consider providing service, linkage to care, all of the things we've talked about already. Bill said the program needs to be FDA approved. 21 CFR Part 11 for electronic signature, so a DocuSign. Thank you for that, Bill. And yes, I want to say even some of the presentations, we've heard about telehealth, those who've been doing it. The signing piece has been an ongoing challenge. So sometimes sometimes people go out and do kind of an onboarding visit with patients in their home, and they get them to sign everything, and then from then on, they're able to move forward. But that's just something that I heard on another telehealth lecture that I listened to. Okay, so we'll come back, Cynthia, to your question about mental health services that could be free for someone who lacks insurance. So we're going to hold on to that. Dr. Lubega, thank you for joining us. We're going to move to our last panelist, Dr. McLeese from the Center for Positive Health, housed in Denver Public Health in Denver, Colorado. And thank you for joining us today and sharing a little bit about your program and the innovations you all have made.
Sure. Hi, I'm Margaret McLeese. Thank you so much, Bev and Ty and Brian, Victoria, for organizing this. I really appreciate the diverse clinical settings that we're all coming from. And Nathan's awesome. His linkage to care, he and his colleagues, they do such a great job. So I am I'm the Associate Director of the ID Clinic, or the Center for Positive Health. We're the Center for Positive Health at the ID Clinic. We are within Denver Public Health, but also part of Denver Health and Hospital Authority, which is the safety net hospital for the city and county of Denver. So we have a very diverse patient population. I have been with my clinic since 2011. I lead all of our quality improvement activities for the clinic, and I'm also the public health representative for our as a liaison to our EPIC, our electronic medical records. So I'm involved also in sort of the shifting technology and how we make those huge lifts to change basically everything we do and how we do it to still do the same things or do things slightly differently. You know, as we were listening, our setting is that we are Ryan White funded clinic. So we have all on the same floor our medical providers. We have a dental clinic, a pharmacy, mental health care, social work, certified addictions counselor, outreach work. We have a clinical trials unit as well. And then we're very lucky to be supported with a linkage to care staff also. We serve about 1,600 clients in our clinic, and then Denver Health, as the safety net hospital system, has a localized or a central campus in Denver, and then we have a network of community health centers. And so we have another group of docs who are internal medicine, family medicine trained, who see our clients in those locations, and they have about 600 more patients in that group. As I mentioned, we're the Center for Positive Health at the ID Clinic. So as providers, the docs, we all do general infectious diseases as well. So that gives a little bit of a different, we're all thinking COVID as well as HIV. And we are trying to get that all mixed, all fit together. You know, as we redesigned how we did everything, because, you know, we're listening to everyone talk about redesigning how we contact our patients, how they get into our buildings, how they interact with our clerks, our providers, the pharmacy, the labs, everything is sort of doing it differently. You know, we really wanted to maintain patient-centered care. We really wanted to make sure that what we're doing supports the social distancing, which is a challenge where we have patients who are experiencing homelessness, and patients who have a lot of, even though we're an urban setting, a lot of transportation difficulties, and thinking through each time you ask someone to go somewhere, what exactly are they doing, and what's that risk? What's the risk benefit of what you're asking them to do or recommending that they do? And then really also thinking about making sure that we're still delivering the right care at the right time to folks, that we are supporting their health, not just with HIV care. You know, we want to support our HIV care. We are supporting folks through their infections with COVID-19, with SARS-CoV-2, and And also making sure that they're not a secondary, a secondary death or a secondary casualty from neglect of their other medical problems and not recognizing those. So in doing that, we've maintained some face-to-face visits. Our volume of face-to-face, we took all of our, much to our, I think our providers' delight, not really, we combined into a central, a single schedule, and we sort of have urgent visits. We are seeing patients face-to-face for intakes that we're getting both folks re-engaging. We're seeing a lot of folks re-engaging into care and seeking out care, and I think this is just an amazing opportunity. Our clients are very interested in their health, and so I think it's a really great opportunity to support that. But I mean, from a pretty busy clinic, we're down to maybe 8 to 12 face-to-face visits a day. So we are doing a lot of nurse triage. Some of our providers who are less busy have taken on those triage. We have done a lot of conversion to telehealth and then also video visits. And that's where we had not done video visits before this as a health system. And so I think because we're sort of a smaller clinic within our health system, and because I have this relationship with our EMR, we were chosen to be one of the first clinics to pilot video visits. So that's been an interesting experience. It is so, and I think our patients really appreciate it. It is so fantastic when it works. But as folks have raised, this is not there are big tech issues and tech barriers to doing those and completing those. Whether people have access, you need to have decent broadband, or speed and range on the other end. And so transitioning to that has been really interesting to see how those go and for whom those work. But man, they're fantastic. We can look at people's reactions and say, yeah, that I think is syphilis. You do need to come in, and so that and just to be able to maintain that personal interaction has been great, but it's been a struggle of frustration for our providers. As we talk a lot about being the pilot site means there's going to be a lot of frustration as you find the problems with it. Frustrations are our end and frustration on the patient's end when tech doesn't work. So we are really, we're doing a tremendous amount of telephone visits, but our overall volume is down. I think we'll see over the next few months both the consequences of those patients who are more engaged and the consequence of the patients who are less engaged. And we've provided our providers with their list of their patient panels and said, please, if you haven't seen them in a while, go through, give them a call, reach out to them, get them on your clinic schedule for a telephone visit if you think they're falling off the radar. Especially our older patients, I think social distancing is really difficult for some of our older patients who really rely on those social interactions of if they're in senior living communities, or especially we're very concerned about our folks who are in nursing homes as well. I'm thinking of challenges that processes. We do a lot of nurse triage. We actually had our MAs, I think one of our other presenter mentioned as well, we do have our MAs do like a virtual rooming and call the patient ahead of time saying, hey, in my case, it's usually like, hey, Dr. McLeese is running a little bit late, but she's still going to call you. Getting them teed up, having our MAs become the tech consultants and getting the patients teed up for making sure that they are set up for the virtual visit. We are doing ours through Epic, and so it's a bit, it is all HIPAA compliant and happy and Epic happy, but it's a bit clunkier interaction than some of the other services like Doximity that I've heard. So there's a little bit of coaching that patients need to get that going. We have really talked to our providers, and we're very fortunate to work with a specialty pharmacy. We've really talked to our providers about doing similar things. Really thinking about whether your stable patient needs those labs. Our medications are so much safer now than they used to be. Like, they'll probably be okay going 8 or 9 months, rather than the, strict 3 or 6 months between labs, and really think about whether people need to come in. Our pharmacy, likewise, we have our own on the floor, or it's not our own. We are lucky to partner with our specialty pharmacy at Denver Health, and so they actually provide a lot of the antiretrovirals. They very quickly switched to delivery service, and I was emailing with our pharmacist. I think we've got 70 to 75% of our clients set up on delivery, and so we're doing same day or next day delivery via FedEx. For patient medications, they're running into barriers with that too. Our pharmacy director said that they're actually having issues with missed deliveries and with clients not coming to the door, or being in secure buildings where it's difficult to get to the client to meet and get that delivery. So those are some of the barriers. We, I think, have gotten our pharmacy for the healthcare system is actually covering the cost of the delivery. So that's an advantage of being affiliated with this large healthcare system. Then we're trying to do 90-day supplies whenever possible. Absolutely. Other things that we, lab work, we are doing some labs here. I think we're all trying to figure out what's the balance. If you're bringing someone in for labs, is there benefit? Should you see them in person anyway if you know they need to come in for labs, versus just a quick in and out, get your labs and go, and not have that additional provider contact? We also have, there are labs at each of the community health centers, so we're utilizing those a lot more so that patients can go and get their labs done at a location within the city that's a lot closer to their actual address rather than coming to our downtown campus. We are working with Nate and his colleagues for PrEP, for the mail out PrEP kits with home swabs, but we also have run into some hitches with the swabs and sort of validation of home testing, that sort of thing. So those, we actually thought they were going live this week, and that's been delayed a little bit. Other things that we are doing, we're actually involved, we are monitoring our patients who have developed COVID, either proven through testing. We are very fortunate that we have in-house testing. We got that up and running pretty quickly. We've had it for a few weeks, and we've been able to expand testing capacity. So our turnaround time is about 12 hours. We have 2 runs a day of a nasal swab PCR. So we're trying to do video visits. We have some, within our healthcare system, 3 drive-up sites where if folks talk to their providers and concerned that they weren't testing, they can actually drive through. And then, we have folks, we're actually doing COVID testing in our clinic, and with all the proper PPE and everything. So if someone comes in and we find out that they have walked in with respiratory symptoms, we are doing the evaluation in our clinics. We're an infectious disease clinic. We've run into really interesting circumstances. We're very fortunate to have very strong leaders with the Colorado Coalition for the Homeless, and who have worked very quickly to get, and also through CDPHE and to get availability for respite beds or hotel rooms for folks who are experiencing homelessness who are diagnosed with COVID and need to self-isolate for that time period. We actually have a group of our internal medicine docs spearheaded a virtual hospital at home, and continuing home monitoring, where we do twice daily home calls. We do video visits. If patients are on MyChart and can do video visits, they can do symptom questionnaires that give triggers if they feel like their condition is worsening. So we're doing both of these things at the same time, learning how to manage COVID and manage it in folks in the general population, trying to manage it in folks living with HIV, and then also trying to deliver appropriate care for our folks who are folks on PrEP and our folks living with HIV. I think that communication is always challenging. I think especially early on, as we were putting in changes to clinic schedules and everything, even I heard patients were thinking that we were closed. Patients were thinking our pharmacy was closed. Getting past those barriers, and then making sure I think now the communication is great. We have the same experience. Our patients love their phone calls. We are having full show schedules where that was not the case. And I think it's a combination of wanting to talk to someone, which we all do, and then also folks are home. They're actually available. They're not at work. They didn't have to pull an extra shift, things like that. So we'll see about the consequences. Hopefully that we're going to be able to use this as a really great time to leverage some of these changes in practice and technology to improve our patient engagement and care.
Thank you so much.
Bev,
you all, I know you all have been doing a lot of different strategies. Thank you for sharing all of those. In particular, I think it's a reminder, if you have homeless communities serving organizations where you live, that would be a great collaboration at this point. If you think about, how are we engaging with people experiencing homelessness and still providing our services, go to those folks who are already doing that work. That may be some of you on this call. So we've got some great questions. We're getting close to the end of our time. I don't want to miss out on trying to address your questions. One big thing I wanted to point out is there is a guide. Well, it was really a Dear Colleague letter that included some guidance that CDC created about managing STIs, and it included addressing syphilis. But I wanted to come back to that, syphilis question. Dr. McLeese, you said, of course, if you were seeing somebody over a video and you see a rash, and like, well, you know what, it could be HIV too, as well. It could be, but if we're treating patients who already have HIV, we rule that out. But again, if you have a video visit, you can assess a rash, but how are we, either of our clinical persons who were on the call, how do you manage syphilis or concern for syphilis in this context? Someone brought that up earlier on as a question.
I think for us, similar to the approach Rob was describing, is really taking a good history and assessing risk, and then trying to come up with a place that the patient can go that puts them at that is as quick and convenient as they can get. I think we still have to continue treating people's medical problems, but just figuring out how to do that in a way that gives them the least exposure. If they have to take the bus, figure out a place where they can get to where they don't, or if you need to send a lift for them or something like that. Trying to figure out the fastest, most expedient way to get the testing done. And then if they need treatment, they're going to need,
Yeah, exactly.
And we haven't switched to give doxy. We're still giving IM penicillin for folks who can take it. I think there are some recommendations for orals for gonorrhea, especially for expedited partner treatment for EPT.
We'll make sure we get that document included in the resources we list related to the webinar. Someone asked about mental health services that are free of charge. I can't see the question right now, but I wrote myself a note. Anyone have, because it sounded like the program, the Blue Jeans program is more of a platform, but anyone familiar with, and you can even put it in the chat box if you like, any mental health services that are free of charge?
Yeah, I can't name service specifics, but we have really had great assistance from our social worker and our mental health provider in gathering together online resources with online platforms for folks who can't access mental health. So those are, and then putting those together in a resource to, like Nathan put it in their after visit summary or that they can access on MyChart.
Great. Thank you. And then someone asked a question about Have you seen any drop in scheduled visits from monolingual Spanish-speaking or other non-English-speaking patients, or medical language interpretation services being utilized?
So I don't know that we've looked specifically to see demographics. We know that drops in services yet. I think that that's definitely a focus on at-risk groups, whether it's younger individuals who are less likely to be consistently engaged in care, or some of our, the more marginalized populations. We are fortunate we still have interpreter services. We are also not able to conference an interpreter onto the video visits, so that's a challenge with those as well.
Okay, thank you. We had a note here from Walgreens that they are now rolling out different drive-up COVID-19 testing sites around the country. Please reach out to your local reps or Sam, who's in the list today. Reach out with any questions. So in case someone spoke about I think Rob spoke about that, the limitations and limits of having access to testing. So it sounds like Walgreens is a resource for that. Someone wanted to hear a little bit more about education with home testing kits. Maribel.
Yes. So this is Rika with Vivint Health. We are currently doing at-home testing where the participant will go to cdnstore.com, and they fill out a survey, a pre-survey and an order. And then once we get their order, we will call them and do kind of a pre-screening and a counseling session, and then we ship out their test to them. Once they get their test, they'll do a virtual call with us via like FaceTime or whatever that might look like. And then we'll kind of instruct them how to run the test and how to read the results. We'll do that together. And then should they need linkage to care, we definitely link them as well. So pretty simple and easy. We're doing it in Denver County for right now, as far as I know. Oh, and we are doing the OraQuick, the oral.
Okay, thank you. I believe someone spoke about that earlier, so thank you for sharing that.
Sure. No
and someone asked, we are talking about HIV and not STI, or all?
Correct, just HIV testing.
Okay.
So, and Bev, just to say, Denver Health, we have a similar home-based HIV testing program as well, with the full linkage to care component as well.
And I will say my colleagues at University of Colorado, I think for their PrEP program, they've actually been doing teleprep for a while, and they use dried blood spots for creatinine, for hepatitis testing, so they can actually do the full gamut of testing for a PrEP visit with a mail-in kit, including some of the monitoring that we think you usually need a blood draw for. So that technology is available. It's all the regulatory stuff you have to get through, and I think they've done that already.
Okay, thank you. I just want to acknowledge that SAMHSA, Unity, and Phoenix have been recommended as having an incredible variety of online support groups, all on Zoom, and they are free. So that's a recommendation for mental health services that are free. So we're almost at the end of our time together. I really, really want to thank our panelists for sharing their processes and expertise. I want to thank all of you for your great questions, having us think about, how we adapt to COVID-19, and thinking about what we're going to keep after things from this pandemic calm down. What are the strategies and tools and maybe the new ways of relating to our population of patients that we're really working, that we may be able to hold on to and continue to improve our provision of care. wanted to remind you all to make sure to enter your full name and where you're joining from in the chat box. If you could do that, we know you named yourself in your Victoria, what do we call these squares? In your Hollywood square. But if you put it in the chat box, that would be great. It helps us with attendance. Also, Brian, did you want to share a glimpse of the resources, or we will just share those after the call?
You want to share the screen? It was sent to everybody on the registration list, so you should have received it. And then I believe Victoria has a way of sharing documents within the chat pod. She just shared the zip file. Is that right, Victoria? Yeah. So I think for everybody to download, did you want to look at it and review it, or is that good enough?
Well, we're just about out of time. I just wanted to make sure everyone knew there's some great resources in there. So please take a look. The other thing I want to highlight here is, and we've been here before with HIV, as we know how devastating any virus can be that impacts the community this way, is considering end-of-life care for patients experiencing COVID or family members, or what that all means. So there's also a resource. There's an Endwell Foundation in California that I follow, and they have some tremendous kind of videos and discussions about addressing end of life and having those discussions. So please utilize all of the resources, and a lot of resources are being posted in our chat box. Thank you again for your time. Thank you, Victoria, for keeping us all coordinated. Thank you, Brian and Jadon, for your partnership. And thank you to all of our panelists for taking time out of your very busy schedules, trying to work around, how to see patients without seeing them. But I believe we all learned, I know I did, I learned a tremendous amount. And hopefully you all took away some ideas or tools or considerations for now and the future.
I just want to.
So thank you. Yeah, Jadon.
I just want to remind everybody that after the session, you will receive an evaluation for the session, and to make sure that you have the opportunity to fill that out. So there's two ways that we can offer these programmings for free, and that is by doing registration and have an evaluation. So you will receive it directly to your email. Please make sure that you fill that out in the next week or so. Today would be awesome, but I also understand it's Friday. It might be warm where you are. You may want to take some time to think about it. But you still have the opportunity to do that on Monday over the weekend. But please do get that evaluation done, because this is a great partnership. We just want to be able to prove that you all are here, and that however you experience the programming, we can have improvements, and this also gives us the ability to host these kind of events again. So thank you so much for everybody for participating. I had something else to add.
Yes, just wanted to say this will be the first of many collaborations between the Denver PTC and the Pacific AETC on this topic. So be on the lookout. We thank you. We loved having you in our virtual Zoom world, and awesome. Thank you.
Thank you all. It's been in your faces too. I love the brave people who decided to turn on their camera and leave it on. I turned mine on a couple of times. So I appreciate those people who left it on the whole time. That's awesome.
Thank you so much, everyone.
Thank you. And this will be recorded. Yes, this will be recorded.
Yes. And we'll let you know when that recording goes out, probably via email as well. So we'll send out the recording and the resources again as soon as we're able.